Good evening, everyone. On the call, this is Uganda Medical Association, Acholi branch, being supported by the National Executive Committee to make sure we give you CPD-rich discussions and webinars. And today we want to share experience and discuss hemodialysis in renal failure. I will not want to talk deep into the topic. We have a presenter who is seasoned and has been doing hemodialysis and care for the patients undergoing dialysis in Teresa Eco International Hospital. Dr. Okot Jimmy is the head of renal unit and also the medical director of Teresa Eco International Hospital. He's a medical officer with special interest in nephrology. He'll be taking us through this session, and there's a reason why we have chosen this by hospital presentation. We'll be going through the hospitals in the region who are supporting the medical doctors in the profession and caring for them. We want to see how we can explore what do they have for the region, what are the patient care modes that have developed, innovations that are supporting the patients and making sure that we have good health practices, and then also we have quality care in the community that we exist in. So this is one of a kind, and we have started with Teresa Eco and the rest of the hospitals, including Lacho Hospital, Care, we have Yotkum, and then other hospitals, including Kalon. We shall be putting them one by one and having them to present what innovations they have and what they can share with the region so that we can know when and how to refer our patients to them. At this moment, I want to call in the Umachia, if he's around, to say a word before we have the presenter. Do we have Professor Kitaro in the call? See if I saw him. All right. You'll join us in. Due to time, let's start the presentation, and then you'll have a moment of showing us what other things you have for us in Teresa Eco International Hospital. At this moment, I'd like to call Dr. Okot Jimmy to dive into the presentation at the moment. Thank you very much.
Yes, thank you so much, Dr. Joel. The moderator, I am Dr. Okot Jimmy, the head of Renal Unit and medical director of Teresa Eco International Hospital in Atiak, Moro District. Our topic of discussion today is hemodialysis in renal failure, the perspective of Northern Uganda. And since I'm presenting from Teresa Eco International Hospital, Mr. Moderator, you may allow me to give you a background of what we are going to discuss. We shall talk about the preamble, that is the background of the hospital. We shall do some case definitions. We look at the disease burden, especially in Northern Uganda and in Northern Uganda in specific. Case definition, that's diagnosis and staging, clinical assessment, indications for dialysis, principles of hemodialysis, vascular access for hemodialysis, pre-dialysis, intradialysis, and post-dialysis complications and care. So in 2 minutes, let me give you a background of this hospital. Teresa Eco International Hospital is a private not-for-profit hospital with a vision of providing comprehensive quality health care to the population of Northern Uganda and Uganda as a whole. Teresa Eco International Hospital Atiak is located in Atiak, Amoro District, Northern Uganda. That's around 70 kilometers along Gulu-Nimule Highway. So we are just at the roadside. This 200-bed capacity hospital arose from a needs assessment conducted by Alliance for African Assistance in conjunction with the Rotary Club of Gulu, Kekal Atiak, and other community leaders in an effort to rebuild Northern Uganda after 20 years of devastating war. You can see on my right in the screen that Teresa Eco International Hospital Atiak, the medical equipment for this hospital was donated by Rotary Club, specifically the Rotary Districts, the Rotary Club of San Diego in California, and Rotary Club of Gulu in partnership with Alliance for African Assistance, which is the organization which is mandated in the day-to-day operation of the hospital. Down on the left, on the right, you see the interior view of the hospital. And this is the external view from the outside at the gate. That is a signpost. We have the services listed. We also have Aiko Institute of Health Sciences. The mission for this hospital is to provide maternal and child health care, disease prevention and treatment with focus on the less fortunate social groups. The vision is to be a general hospital serving the population of Northern Uganda. Our core values is the respect of human dignity and care. On my left upper corner, you will see the reception. We are going clockwise. That is the interior view of the hospital. The upper stairs is where the institute is located. We have an ambulance on the right lower corner, which is important for medical emergency transportation. And on the left is the Eco Institute of Health Sciences minibus. So let's dive into renal failure, the disease burden. Up to 70% of patients with kidney disease live in low and middle income countries, Uganda inclusive. Now, renal failure is an important public health challenge in sub-Saharan Africa with an estimated prevalence of 13.9%. In Uganda, however, the prevalence of 2 to 9 exists in the community and is the leading cause of death. Renal failure is among the top 10 causes of death in Uganda, with a case fatality rate of 21 among admitted patients. However, 90% of patients living with kidney disease do not know that they have it. Now, that underlying part is going to be important. It's a public health challenge then, that if 90% of the people with the kidney disease are unaware that they have it, that calls for a public health effort. The case fatality rate of renal failure in an intensive care unit, however, in Uganda ranges between 52.5% to 74.1%. This is a little bit high. The primary drivers include hypertension, diabetes, HIV, obstetric complications, for example, postpartum hemorrhage, and severe infections like malaria. And the last one is most common in children and in the geriatric patients, older age group. Because early symptoms are often silent, patients frequently present at advanced reversible stages, like stage 5, which requires dialysis. In this case, we as Teresa Eco International Hospital, we are doing hemodialysis. There are two modalities for dialysis: peritoneal dialysis and hemodialysis. Hemodialysis is currently not widely available in northern Uganda. The primary public and private centers for hemodialysis are concentrated in the central region, and patients from the north often face costly, long-distance travel to specialized facilities in the central region. Health facilities in northern Uganda currently performing hemodialysis are St. Mary's Hospital, Lasho, which is always referred commonly as Lasho Hospital, Lira Regional Referral Hospital, and Teresa Eco International Hospital, Atiak, in Amoro District. Let's look at some definitions. Renal failure or kidney failure occurs when kidneys lose the ability to adequately filter waste products. In this case, basically, we are centering on urea and creatinine, but of course, there are other waste products, fluid, and electrolytes from the blood. It's divided into two primary categories. We have the acute kidney injury, we commonly call it AKI. Formerly, it was known as acute renal failure, and chronic kidney disease, CKD. Now, how do we make a diagnosis or know that a patient or a client has acute kidney injury? It is defined as an abrupt, within hours, decrease in kidney function in two aspects: the structural damage, which is also followed by loss of function or functional impairment. We have the AKI criteria, and that is an increase in serum creatinine by 0.3 milligram per DL within 48 hours, or increase in serum creatinine by 1.5 times the baseline if you have been monitoring the baseline which is known or presumed to have occurred within the prior 7 days. Or you can use the criteria for urine output of less than 0.5 mils per kilogram per hour for 6 hours. Acute kidney failure we're looking at the etiologies and the classification. So let's look at the pre-renal, the renal, what's called the intrarenal, and then the post-renal. The pre-renal causes include the impaired perfusion. Basically, we're looking at the blood flow to the kidneys. When there is impaired perfusion to the kidneys, probably due to cardiac failure, sepsis, blood loss or hemorrhage, severe hemorrhage, for example, in postpartum hemorrhage, dehydration, especially in children and geriatric patients, vascular occlusions like renal artery occlusions or renal artery thrombosis. And then you have the intrarenal causes like the glomerulonephritis, which has a wide array of causes, small vessel vasculitis or vasculitides, acute tubular necrosis, like drugs, toxins, and prolonged hypertension. And then you have the interstitial nephritis, which can be caused by also drugs, toxins, and inflammatory diseases like systemic lupus erythematosus, SLE, and also infections that affect the nephrons or the kidney nephrons themselves. And then you have the post-renal injury due to urinary calculi or urinary stones, retroperitoneal fibrosis, benign prostatic enlargement, prostate cancer, cervical cancer, and urethral stricture or urethral valves, or meatal stenosis or phimosis. Now, how do we classify this AKI, acute kidney injury? We have 3 modalities for classification of AKI. There is a RIFO classification, there is the Akin criteria, and then the DIGO criteria, which is in the next slide. So let's start with the RIFO classification. The RIFO classification was published in 2004 in Critical Care. It is a journal. This looks at renal failure in 2 perspectives. We classify as RIFO is an acronym for risk, injury, failure, loss, and then the end-stage renal disease. So here we look at the serum creatinine or the glomerular filtration rate and the urine output. So if the serum creatinine has increased by 150% or the glomerular filtration has decreased by 25 to 50%, that is a risk. And we are going to correlate this with the Akin criteria. And then if the serum creatinine has increased by 200%, or the glomerular filtration rate has reduced by 50 to 75%, that is categorized as injury. And then we have failure, which is an increase in serum creatinine of 300%, or glomerular filtration rate more than, glomerular filtration rate reduction by 75%. So here the criteria uses serum creatinine and glomerular filtration rate. On the other hand, you can also use the urine output. Urine output less than 0.5 mils per kilogram per hour for 6 hours. Remember the definition of the AKI we have just said. That is risk. And in Akin, we call that stage 1. Urine output of less than 0.5 mils per kilogram per hour for 12 hours. Yes, that is categorized as injury. And in Akin criteria, that is stage 2. And then you have urine output of less than 0.3 mils per kilogram per hour for 24 hours, or anuria. Anuria is just absence of urine for 12 hours. That is failure, which is in Akin criteria, it is class 3, stage 3. Akin is an acute kidney injury network. It was also published in Critical Care Journal, 2007. This uses specifically the serum creatinine and urine output. Serum creatinine increase vis-a-vis urine output reduction. So in stage 1, you have the serum increase from 150 to 200%. That gives you stage 1, or urine output of less than 0.5 mils per kilogram per hour within 6 to 12 hours. Then stage 2 is 201 to 300% increase in serum creatinine, or a urine output decrease of 0.5 mils per kilogram per hour for more than 12 hours. And then stage 3 is more than 300% increase in serum creatinine, or the patient is already initiated on dialysis, and urine output of less than 0.3 mils per kilogram per hour for more than 24 hours, or anuria for more than 12 hours. This gives you akin stage 3. We also have the kidney disease improving global outcomes, which we call the KDIGO, classification of AKI. This is similar to the akin criteria. If you look, stage 1 is serum increase by 1.5 to 1.9 times the baseline, or increase of 0.3 milligram per deciliter. That is stage 1. Stage 2 is 2 to 2.9 times the baseline serum creatinine, and then stage 3 is 3 times the baseline. Or this, you can use also the percentages, 150% to 190%, 200 to 290, and this is 300% increase times of the baseline. In the urine output, is just similar to the akin. Allow me to proceed to the next slide. That is the phases of acute renal failure. The clinical progression of reversible renal failure occurs in 4 phases. Underline the word reversible renal failure. There is an initiation phase, and this begins with initial insult or damage, and then ends with oliguria. And then there's what we call oliguric phase. The oliguric phase is accompanied by rise in serum concentrations of substances usually excreted by kidneys, and that is the urea, the creatinine, uric acid, organic acids, intracellular cations, potassium, very important, especially in the monitoring of patients with renal failure. Urine output will be less than 400 mils per day, which is the classic definition of oliguria. And this may last about 1 to 3 weeks. There's a diuretic phase, which is the third phase. The kidney begins to recover. That is if the kidney is able to recover. So in this stage, the patient produces a large amount of urine. Initially, it is hypotonic urine, and there is also an increase in glomerular filtration rate. Lastly, is the recovery phase. Thank God, there is tubular function restored, and diuresis subsides, and the kidney begins to function normally again. This is a natural progression of reversible renal failure. What about the chronic kidney disease, the CKD? And this is the majority of patients with kidney failure. It is defined as the presence of an abnormality in kidney structure or function persisting for more than 3 months. And this includes one or more of the following. The normal glomerular filtration rate limited at this point is 60 to 120 mils per minute per 1.73 meters squared. So if you see in that semicircular diagram, it shows 60 to 120, that is the green, and then 15 to 60, that is the range of the kidney disease. And then when it is less than 15 mils per minute per 1.73 meters squared, that is the definition of kidney failure. So how do we then make the criteria for chronic kidney disease? 1 or more of the following: a GFR less than 60 mils per minute per 1.73, or albuminuria, which is urine albumin more than or beginning from 30 milligrams per 24 hours, or urine albumin to creatinine ratio, what's called ACR, of more than 30 milligrams per gram. The third criteria is the abnormalities in urine sediment, histology, that is the pathological studies, or imaging studies suggestive of kidney damage. Number 4 criteria, the fourth criteria is the renal tubular disorders, if they're available, or the history of kidney transplantation. So who are the people at risk of chronic kidney disease, or potential risk factors for susceptibility to an initiation of of chronic kidney disease. The clinical factors include diabetes, especially patients with chronic uncontrolled diabetes, uncontrolled hypertension, autoimmune diseases, for example, SLE, systemic infections, like we have just given another example, like malaria, urinary tract infections, especially the ascending urinary tract infections that can ascend up to the pelvis and then the nephrons. Urinary stones or urinary calculi, lower urinary tract obstruction. For example, we just stated benign prostatic hyperplasia or prostate cancer. Neoplasia, especially pelvic neoplasia or malignant intra-abdominal neoplasias or cancers. Family history of chronic kidney diseases is a risk factor. Recovery from acute kidney failure, we are going to see, and then reduction in kidney mass, exposure to certain drugs. There are some nephrotoxic drugs. Low birth weight is a risk factor. And then you have the socio-demographic factors like older age group. In the US, for example, African Americans or American Indian or Hispanic, exposure to certain chemicals and environmental conditions that are nephrotoxic, low income or educational status. I want to give a brief etiopathogenesis of chronic kidney disease. Let me use diabetic and then the hypertension. Of course, we said that a chronic acute kidney injury can progress to chronic kidney disease. We have what's called diabetic nephropathy, and this is a case where a patient of diabetic mellitus or uncontrolled case of diabetes hyperglycemia persist and then produce reactive oxygen species, and this enhances the release of growth factors, cytokines, and oxidative stress. And this will result in glomerular basement thickening and sclerosis, podocytopathy, and mesangial proliferation expansion. This array of steps in the progression of renal failure will lead into the decrease in glomerular filtration rate. In hypertension, however, the pathology progresses from hyaline arterial and atherosclerosis, narrowing of the afferent vessels, reduced renal flow, and then enhancing the renin-angiotensin-aldosterone system, further exacerbating the hypertension. Remember, this patient is already hypertensive, and this is again, this pathological process is again enhancing the hypertension and glomerulosclerosis, ischemic injury to the nephrons, and affecting glomerular filtration. Others include like polycystic kidney disease, and then other causes of glomerulonephritis. So when you suspect that the patient has kidney failure, we are supposed to do a detailed history taking, general physical exam, and systemic physical examination. You assess the fluid status of the patient and look for signs of electrolyte imbalance. And then two, we do the phasing. If it is AKI, you need to identify the phase. In which phase is this patient? And then you go to the lab workup, which we are going to see, and then you do the staging. If you have identified that this is an AKI or CKD, we need to do the staging, which is important in management and follow-up of these patients. So the clinical presentation of this patient as you do the physical exam is related to increase in the waste products in blood, specifically urea and creatinine. This is going to produce features of neurological features like atherexis, seizures, somnolence, and coma, or fatigue, weakness, and headache. These patients may also present with nausea, vomiting, and remember, we say that dehydration or decrease in fluid volume is a risk factor for chronic kidney disease. And again, these patients are presenting with vomiting. So this is going to exacerbate the dehydration, which is already caused the kidney injury. You have what's called loss of appetite in the skin. You may have skin changes, color changes like hyperpigmentation, conjunctival pallor or palmar pallor. You may have pruritus. In the chest, you may be able to identify pulmonary edema if there is fluid accumulation in the third space. We may have uremic pericarditis. This is critical. You may see this in physical exam. Also in ECG, you may be able to see fissures in the ECG. Pruritus as a result of accumulation of those waste products. Hypertension, of course, because now the glomerular filtration has reduced and there's fluid retention. A decrease in urine output. Remember, we have just said that there is a decrease in glomerular filtration rate. Albuminuria because of the kidney damage. Hematuria. Paresthesis or dysesthesia, especially periphery. You may have these patients also presenting. Why do they present with anemia? Because of the decrease in erythropoietin, which is important for erythropoiesis. And there's increase in the risk of infection because of impaired immune system. And because of platelet dysfunction, these patients may also come with increased risk of bleeding. You may also have these patients presenting with peripheral edema. Most of these ones are peripheral pitting edema. Some of these patients will come with anasaka, which is peripheral pitting edema or peripheral edema, pulmonary edema, and then facial edema. And specifically in these patients, the facial edema is worse in the morning or in the early hours of the day, and then it subsides in the course of the day. We then go to diagnosis, that is the lab investigations. On my right is our laboratory, which we are able to do most of this test. First, we start with the blood urea nitrogen, the serum creatinine. These two are critical because they will give you an idea of the renal function. The glomerular filtration rate, there is a formula for that. The normal is, we say it is 60 to 120. And then this helps also in the staging of the kidney failure. Albuminuria, this is seen in urine. You may also do a renal ultrasound scan where you will see renal atrophy, polycystic kidney disease if there, and decreased perfusion if you can do Doppler. We have also renal biopsy and serology for the different causes of glomerulonephritis, and also the features, the pathological features of glomerulonephritis if they are able to be seen. You have serology, for example, HIV, hepatitis, and ANA and ANCA. This HIV and hepatitis test is important also when you are going to initiate these patients on dialysis, because some of these microorganisms can traverse the membrane, which is in the dialyzer, and it is important to screen these patients for HIV and hepatitis specifically. Anemia studies, for example, complete blood count will give you CBC pictures of this patient. Iron studies are also important, as we are going to see some of the drugs that we give in these patients who have chronic or who have kidney failure. Electrolyte studies, potassium, phosphate, calcium, sodium, chloride, and bicarbonate. Lipid panel is also important. So the KDIGO staging of chronic kidney disease are in five stages. Stage 1 is where the glomerular filtration rate is less or equals to 90. Greater or equals to 90 mils per minute per 1.73. Stage 2 is glomerular filtration of 6 to 89. Then you have stage 3. Stage 3 is divided into 3A and 3B. 3A is glomerular filtration of 45 to 59, and 3B is 30 to 44. Now we are going to stage 4, which is 15 to 29 mils per minute. And then you have the end stage kidney disease, which is stage 5. Unfortunately, as you heard, epidemiologically, most of the 95% of these patients who come, first, they don't know that they have the disease. Secondly, they come when they're already in the stage 5, which is indicated for dialysis. So then how do we manage renal failure? So we have done our clinical assessment by the clinical team. This is what we routinely do in our hospital. Then you go for the laboratory workup, as we have seen, renal function test, electrolyte, urea, and creatinine, and also extended electrolytes. The decision to initiate hemodialysis depends on the clinical assessment, glomerular filtration rate, serum creatinine, blood urea nitrogen, fluid status, and clinical assessment. You may also decide to manage conservatively, and if there is a definitive indication for dialysis, you do what's called pre-dialysis assessment and counseling. where we do pre-dialysis counseling, vascular access, clinicians prescribe the dosing of hemodialysis, dialysis initiation, the connection, the monitoring of the patient, the machine, and the final destination. Post-dialysis assessment, which involve the post-dialysis vital status and patient feedback. So if you assess this patient and you find that maybe the patient is acidotic with Kussmaul breathing or drowsiness, you may have to treat conservatively with the ringer's lactate or sodium bicarbonate.